Hello, welcome everyone. Thank you for joining us today. Shaun, Brewster, Bodine, Ledden here today, chatting to you about the questions that we get often asked at dry needling courses by people that we're training. So this is something we've been wanting to chat about for a while.
Yeah, definitely. These are questions that we see almost every course to the point where we've started to put these in as slides in the course because every course will have the same sort of questions come up. So yeah, I think this is a great topic to address and discuss these common questions.
Yeah, absolutely. And I've found in my experience too, these questions don't just come up by newbies, people who are just starting out their training in dry needling. This often get asked to us after the fact. People will come across in the industry who have been practicing dry needling for a while, and they'll go, you know what? I do have this question that's always plagued me in the back of my mind, and they'll ask it, and it's sure enough, it's one of the same questions that we get in the course as well. So let's put this into a podcast. We'll chat about it and give our best answers for everybody.
Yeah, definitely. Yeah, as you said, we always get those questions, and sometimes it might be, I saw someone that was doing this type of stimulation, and they told me that I need to leave the needle in for this time period. And we get those questions. We go, well, it really is patient dependent. There's no specific answer. So, I guess that's probably where we could start. Is first question: how long do I leave the needle in for?
Yeah, this is the question that you get in every single course, and it's a question that it's a reasonable question, right? Like, how long do I do it for? And this goes for every modality. How long do I apply that massage technique? How many repetitions, or how long do I apply that mobilization for? How long should the tape be left on for? How long should I hold the stretch for? Like this time dependent question, and I feel like our answer is going to be the same for most of these things, which is it depends, right? It depends on so many variables. What have you got on this one, Bo?
Yeah, well, that's it. It does depend on the patient, their level of symptoms, their level of irritability, how long they've had the symptoms for, if they've experienced dry needling before, how they typically respond to it, their lifestyle factors. So there's a lot of different factors that can play into it. But when we look at it, it's sort of there's no evidence to suggest that um, a certain needle stimulation type is better than another, or a specific duration is better than another. We just don't have that research, and it really will depend on the patient. So I think when we look at, well, how long should we leave it in for? Well, what are the symptoms that the patient is reporting? When we look at treating someone's pain, and that could just be with an ischemic pressure, right? What we're aiming to do is elicit their familiar symptoms. We might hold it until their symptoms start to diminish. Okay. And then we might press in that little bit further, bring those symptoms up, allow them to diminish. Now it's the same with a needle. Don't just leave it in there and hope for the best and think that it's doing something magical, and it's very time dependent. Well, we're looking to have that constant discussion and feedback from our patients so we can see, well, what's your level of symptoms now? Once that starts to diminish, we might re-stimulate that needle with various different techniques. If they're not reporting any more symptoms, or their symptoms have diminished, they've had an analgesic effect from that needle, we can take the needle out and move on. For some people, it might be quite a short period. For some people, it might be a little bit longer.
Yeah, absolutely. And I think we've also got to come back to, with any question when it comes to time or stimulation type or anything, we've got to come back to what are the mechanisms at play in any manual therapy technique we use. And dry needling definitely has well researched, well evidence-based mechanisms at play that we can sort of hang our hat on and say, okay, well, the effect we're getting primarily from the needle insertion is we're getting some mechanical effect at the tissue, we're getting some neurological effect, and we're getting some chemical changes. When the needle's left in situ and it's just placed there and the patient can no longer feel anything, we're not doing anything to the needle, they're no longer feeling any stimulus from it, we can, looking at the different mechanisms, we can kind of say, well, it's probably not doing much. A lot of the effect that we get from dry needling is through the stimulus. It's through sensory feedback to the nervous system. And so if a needle's placed there and that patient goes, right, I can't feel it, I'm not feeling anything, I'm not getting any sensation, well, then that's probably not providing any information to the nervous system. Therefore, it's probably not doing anything for them. It's not to say that we then can't come back and stimulate the needle and reproduce something or produce some kind of stimulus and move that effect along. But if we're just letting it sit there while we go off and work on another part of the body or write our notes or do something like that, the therapeutic benefit kind of tapers off. And I think that that's key thing to consider.
Yeah, really well said. But also think that it's not that we need to make it painful. We're looking to elicit their familiar symptoms and wait for that to diminish. So as far as, the time that needle is left in or the amount of stimulation, it's not that you want to go in and really overstimulate it with a lot
No.
of listening techniques, because that could potentially just aggravate symptoms and make them worse. This is unnecessary disruption of tissue. So it's really going in, stimulating that needle, having that constant feedback with the patient, and doing just enough, not too much. More is not better with needling. It's not that if you leave it in for 25 minutes that it's better than leaving it in for 1 minute. And same goes for the level of stimulation.
Which probably brings us to our next question, right? Which is, how much should I stimulate the tissue with a needle?
Yeah, this is a good one. Again, it's going to depend on the person and their level of symptoms and sensitivity. There's numerous different stimulation techniques, and the most common being like a winding technique or a pistoning technique. And again, it really comes back to eliciting their symptoms. And if you're stimulating that needle and the symptoms have diminished, you're done. You don't need to do any more.
That's right. And I think you touched on something there about the sensitivity of the patient. That's a really key thing. And I see this as there's two different sides to this answer. One is, how sensitive is the person? And so their threshold for pain or sensitivity may be lower. And anyone, particularly people in chronic pain, typically have a lower threshold for activation of their nociceptors. And so a very gentle, very subtle insertion with not much winding, not much pistoning, it might just be a subtle lift and drop of the needle, or even like a flick of the head of the needle, the handle of the needle might be enough to spike their symptoms back up to that point where they go, yeah, I can really feel it now. That's it. We let that settle down the same way that we would treat a trigger point if we're using ischemic compression or any other kind of manual therapy technique. Let it settle down. We give it the appropriate time, and then we repeat that until we can no longer bring on the symptoms. That's one side of it. The other side of it I see is, okay, well, beyond and outside of trigger point dry needling, we have other things that we can do with needles. We have a mechanical interface between the needle and the tissue. We can use things like winding and pecking to create other effects in tissue, mechanical effects in tissue, stretching of connective tissue and other different things. And I know a lot of that side of dry needling isn't well researched, so we can't sort of say for sure that it's doing what we think it's doing, but there's absolutely a mechanical effect that we can perceive and feel and often even see. And so if we're using, for example, a winding technique on tissue to create a local stretch in the connective tissue, well, then is that appropriate for that person? Are they already very sensitive, and is that going to be too strong for them? Or is the tissue that we're trying to affect in that way, is that technique appropriate? Is there a mechanical or is there a clinically reasoned need for that technique? So I see a lot of practitioners, or actually a lot of students coming to our courses, and they'll say, I went and saw XYZ practitioner, and every time they needled me, it was this very aggressive pecking technique. And I felt like that was how dry needling's done. And it's absolutely not. It's how that practitioner does dry needling. And we have to remember that there's lots of different approaches, and we need to selectively choose the one that is appropriate for the patient, not the one that we like doing.
Yeah, that's a really good point there, both of those points, and I think like when you do look at it from that highly sensitized chronic pain patient who perhaps has not had dry needling before, or they've had a bad experience, we may not need to needle them to completely diminish their symptoms. It might be a very a small dosage of needling where we insert the needle. It might be left in for a very minimal amount of time, and then it comes out, and that's enough, to change that input, because, by continuous stimulation of that needle, that could potentially be perceived as noxious. All right. And that can contribute to the overall sensitivity in the dorsal horn. And that could, again, be not an effective approach. You sometimes see people that will use 15, 20 needles in a region, and it's like, whoa, that's a lot. That's a lot of stimulation. And for the wrong person, that could be quite provocative and irritable.
Definitely. Yep. And so it's a dosage question, right? Like how much should we stimulate the tissue with the needle? Well, what's the appropriate dosage for that person on that day in that given time? So it's not just, okay, this is a fit, strong, healthy, athletic person that can handle more stimulation. No. Maybe they've just completed an ultra marathon, their body's fried, their nervous system is wound up to 100, and they need to actually desensitize. They need to reduce sympathetic activation, and they need less. In fact, maybe they don't need dry needling that day. Maybe they need a relaxation massage. It could be anything. So all of the manual therapy techniques that we have, dry needling and everything else, provides input to the nervous system. And so dry needling with the potential to give a lot of stimulation, we have to really consider dosage with it.
Yeah, really well said. I
Yeah.
agree. All right, so let's move on to the next question. Why does the needle sometimes cause a stinging sensation and sometimes an ache?
Yeah, it's a good one. So this is a question that I love answering as well in courses because it helps people understand what they're doing and it helps them understand the patient experience. It's also why we really strongly encourage all participants to receive dry needling in the courses so they can understand that side of the experience too, because we've all had muscle pain before and we know what that feels like. We've all had a paper cut or stood on something sharp and we know what that feels like. And they're two vastly different experiences. And so the interesting thing is we can have a needle inserted into our arm, leg, back, whatever, and we can experience both of those things. We can feel a sharp sensation, stinging sensation, and we can feel a dull ache with the same needle and the same insertion. And we think to ourselves, well, hang on a second, sharp object going in, that makes sense, sharp sensation. Why then at a certain point does it become dull? And it comes down to different kinds of sensory nerves, right? And the proliferation of certain types of sensory nerves in certain types of tissue. Did you want to talk a little bit about that?
Yeah, I agree. And we see this all the time, especially when we start a dry needling course, when someone might be a little bit apprehensive of inserting the needle. And, we start on the forearm and someone might put the needle in and they go, oh, it's really, really sore. It's really stinging.
Yep.
And we go and look at it and we can see that it's only just in the surface, just in the skin. So they often think, well, have I hit a nerve? Well, not necessarily. There's a lot of free nerve endings that sit in the skin, right? And these are those A deltas, and they're very important because they protect us and alert us from external stimulus that could be potentially threatening. All right. So that sharp sensation gives us that withdrawal reflex. Now, because a lot of those A deltas sit in the skin, when we insert the needle, we often need a really nice firm tap to pass through the skin and that superficial tissue, right? And then also a lot of those A deltas will sit in the epimysium, so that fascial surrounding of the muscle. So if you're pressing just up against that epimysium, it can provide a bit of a stinging sensation. So you'll notice you'll feel this change in texture. So as you pass through that epimysium, it'll start to get a little bit thicker as far as the resistance. But the patient will go, oh, now that's just this dull, heavy ache. A lot of those C fibers, your typical nociceptors, those unmyelinated, slow conducting nociceptors, they often sit within the muscle. And, so there's a higher density of C fibers within the muscle fibers. So, and that's typical of your trigger point pain, right? You've got these sensitized nociceptors that provide this dull, heavy, aching type sensation. So when we use dry needling, that's essentially what we're trying to recreate. We're trying to recreate the patient's familiar symptoms. And but yeah, so it's important to differentiate and ask your patient, well, tell me a little bit more about those symptoms. Because if you go into the skin and they go, oh, that's stinging, that's burning, that's shooting down to my fingers, okay, well, that could potentially be a nerve, right? So we need to differentiate those types of symptoms. And then, if we were to move that needle or slightly bring it out, does that settle those symptoms down? All right. Do we redirect it? Does that also change the symptoms? So having that communication with the patient is important so that we can know, well, is it just a free nerve ending? Is it actually a cutaneous nerve that we're pressing up against? Or is that dull, deep, heavy, aching sensation, is that when we pass into the muscles and we're detecting different types of receptors and nerves?
Absolutely. And I think that fact about the A deltas being more predominant in the superficial tissues and the fascial boundary of a muscle, and then the C fibers, we find more of those deep in the muscle belly. That allows you to then go almost visually with the needle into the tissue and go, right, where am I? And so if you're needling somebody and there's a degree of adipose tissue between the skin and the muscle, and you think, okay, am I deep enough yet? Am I in the muscle? Well, there's two things to rely on there. One is the sensation from the patient. They'll say, oh, now it's dull, achy. And you go, great. I'm most likely then I'm in the muscle belly. And around about the time that sensation changes for the patient, for the therapist guiding that needle, they'll feel this soft tissue, soft, and then they'll hit the muscle and they'll feel some resistance and they'll kind of pop through into the muscle belly. And that's when they get the change in from sharp to dull often. And that's a beautiful thing as a practitioner, because you can really tell where you are with the needle. You don't have to guess. It's almost like using real-time ultrasound to a degree. You can sort of go, right, it's a bit stingy, it's a bit uncomfortable. Now it's achy. Great. That's where I feel the tissue texture change. And it's also where they perceive a different sensation. I can be pretty confident that I'm in the muscle belly and I'm where I need to be.
Yeah, and that's the real skill of a good dry needler, isn't it?
It is.
Is feeling what you're passing through, knowing where you are, having that constant feedback and communication with your patient. Because if it is stingy and uncomfortable, don't keep pushing, stop, ask them. If it's still too uncomfortable, take it out. Try a different spot. But we can get some really great effects by, having that constant feedback and communication with our patient can improve the outcomes.
Definitely. What else have we got there?
All right. So next question, how often should I needle someone?
Every 2 hours for the rest of their life, I think is the answer to the question, isn't it? How often? It's a little bit like our stimulation question. The dosage has to be appropriate for the person, I think. What's the clinical presentation? What's the clinical reasoning behind your application? You can definitely overstimulate someone in a session, but you can also overstimulate them over a period of time.
Yeah, definitely. And the thing is, like, realistically, if we thought of it from a very basic point of view, where we needle the trigger point, if we can sort of change what's happening at a cellular level, all right, theoretically, we shouldn't need to continually go back and keep treating that same area. When we look at education about what's the potential drivers, exercise, strengthening, improving capacity around that area, we shouldn't be constantly doing the same treatment repetitively over a longer period of time. You might have a more intensive dose of treatment in the short term. Over a 3 to 4 week period, you might be needling them multiple times a week, or it depends on how often you need to see that particular patient. But, not doing that long term on months and years, So as far as how often, as far as the frequency or the dosage, you could, if you were seeing them 3 times a week, then you could needle them 3 times a week if you wanted to, if you needed to, and if it was indicated to, realistically, if we're getting some really good responses with our needling, we should be progressing away from that and moving to more of an active intervention.
Yeah, that's right. And people will often ask, can I needle every day if I wanted to? And it's usually because they want to needle themselves, because we don't often have access to our patients every single day. But, I've got this trigger point that haunts me in my rec fem. Can I needle it every day if I want to? Well, you could, but try that and see what happens. I think you'll find that even with the small amount of trauma that we get from a needle, and there'll be some damage to muscle fibers and disturbance to tissue with a needle, and for the most part, that's not problematic. But if you do that every day and the tissue has to continually repair and try to heal, then you start to get a bit sore, and you create a very small inflammatory response. And if that doesn't quite get to go through its full cycle, and then you re-irritate the tissue again, pretty soon you start to create its own set of problems as a result of the needling instead of the actual therapeutic benefit you want. So too much of something doesn't make it better. It is that right dosage. And yeah, you could probably needle somebody 3 times a week if you wanted to, and that might be appropriate. But realistically, we see our patients maybe once a week, maybe twice a week, depending on the presentation. That's fine. You'll be okay with that. But you're absolutely right. Manual therapy should be used as a gateway to get to the next step. And the next step should involve more patient interaction, more patient involvement. And that's usually exercise, activity modification, nutrition, diet, sleep, all these other things that really make the long-term changes. And so I think the question is kind of flawed, isn't it? How often can I treat them? It's, well, as few times as possible to get the beneficial effect you want, and then move on to the next most appropriate thing that gets them out of your clinic and out of your life, because they shouldn't be having to rely on us long term.
Yeah, that minimum effective dosage. And, you know, when we look at dry needling and other manual therapies, it's a fantastic way to modulate pain
Yep.
short term, you know, so we can get some really good responses without adding additional noxious input. Like dry needling can be far less painful than a lot of manual therapy approaches. Like, for example, if you're putting a needle into someone's glute med versus your elbow, you know, I know I'd prefer a needle. So we could modulate their pain without increasing any noxious input to their central nervous system. So I think that's really important. You know, and as far as post-treatment soreness, yeah, that can happen. But the more stimulation that you do, the more needles that you use, is the more likely that they'll have more post-treatment soreness.
Yeah, that's right.
So I guess that sort of leads into the next question is, should my patient be sore after needling?
Mm. Yeah, this is a question I think is a really important one to address, not just for needling, but for all the things that we do clinically. And it's become almost an expectation that after a treatment, a manual therapy treatment, you'll be sore. And we're often taught, I know I was taught that, say after a massage, for example, patient will often pull up sore, and you just explain to them that that's normal, and that they'll be sore for 24 hours, 48 hours, and it shouldn't continue much longer. And if they move and exercise and eat and sleep and do all that stuff, then it should reduce it. But I actually don't believe that anymore. I think that post-treatment soreness is an indication that we got the dosage wrong. We did something wrong. Now, you can't always nail it. You can't always get the dosage exactly right. But I think the better we get at what we're doing, the more we understand mechanisms in the effect that we're trying to achieve and the modalities we use, the closer we can get to not just getting the right dosage, but the right combination of applications, so that the person walks in discomfort, walks out without discomfort, and they shouldn't have post-treatment soreness if we get that right. And so I think that we've got to change that paradigm and that way of thinking, that it's okay, if all of our patients are walking out sore the next day and we're telling them you can expect to be a bit tender, well, then we've got to look and maybe reflect back and go, what are we doing that's setting them up for that pain? Maybe we're too aggressive with our stimulation. Maybe we've used too many needles. Maybe we've used needles and too many other things. I think we need to look at what we're doing that's creating that pain, rather than just give them the expectation that that's what they'll have.
Yeah, I agree as well. You know, it shouldn't be that it's too uncomfortable that I couldn't move for 2 days. It's like, well, that's an ineffective treatment.
Yeah.
But in saying that, you know, there are certain muscles that just present sore afterwards, like gastrocs, upper traps. It can be glute med, glute min. These muscles that are under high amounts of load, particularly if the person is a little bit sensitized and sore through that area, they might pull up a little bit tender, but tender shouldn't mean that they are painful, that they couldn't go about their normal activities, or it stopped them from doing anything. So I think that's really important, that yeah, you might feel a little bit tender, but if it's too much that it's really, I could notice it for the next few days, then yeah, that's too much.
That's right. Yeah. And I think it's just probably just a bit of a hangover from the no pain, no gain concept that, was embedded in manual therapy for eons before we even got to it, right? Like, it's like, if you're not hurting them, you're not doing it right. It's just not true. It's just such an old, outdated and flawed idea. We shouldn't be adding more noxious input to someone who's already got too much noxious input. We should be doing the opposite of that.
Yeah, for sure. Okay, so that leads into another question. Should my patient avoid exercise after dry needling?
Good question. That does sort of follow it, doesn't it? So I think we have to, again, consider what are the outcomes or the effects of the modality we've chosen. So if we're looking at dry needling, and dry needling can produce various different outcomes based on the stimulation we apply. So if we use a very low dosage, subtle stimulation style, where we pop a needle in, get a very moderate sort of dull ache, leave it for a bit, settle down, occasionally come back and re-stimulate, and just kind of leave it at that and take it out, well, then you're sort of setting the person up for healthy, normal function of that muscle, right? That's ideally what we're trying to achieve. But if you come in and you hit a bunch of trigger points in a muscle, use lots of aggressive stimulation, lots of pecking, lots of pistoning, get lots of twitch responses, including a lot of that acetylcholine from the tissue, it's more likely that that person's going to walk out with probably an inhibited muscle, walking away feeling a little bit weaker, the muscle's not firing as effectively, or it feels like it's not recruiting as effectively. And so if that person then comes off your treatment table and goes out and tries to go for a run, they might feel like, oh, geez, my legs aren't really kind of working like they normally would, or I don't have the get up and go that I normally would. Well, yeah, it's because you've stimulated the tissue in the nervous system in such a way that it decreases the appropriate level of tone in the tissue. It's the same reason that we give somebody, like, for example, a pre-event sports massage, or they do dynamic stretching or something that kind of pairs the tissue for performance. Our treatments can do the opposite of that if we apply the wrong stimulus.
Yeah, so I mean, I use needling to reduce inhibitions to movement and exercise. So in the session, I will needle them and then immediately have them doing exercise.
Yep.
Immediately have them doing what they came in complaining that they can't do. All right. So that's the point here, is that we use a manual therapy intervention to allow them to get back to normal function. So if someone's got shoulder pain, they're struggling to reach up overhead, all right, we might apply a manual therapy intervention, dry needling, joint mobilization, whatever it may be, so that they can then immediately go into some overhead work. And then once they've got that pain inhibitory effect or that analgesic effect, then we can load it. We can start to get them moving, get them more comfortable with that movement. So I personally think that we should immediately be combining that together. I mean, that's not the case in all people. Some people are really highly sensitized, and we might need to do a little bit less. But from quite a general point of view, we shouldn't be, if we apply any intervention that means that the person can't go and exercise afterwards, and that was too much, or that was the wrong intervention. We should be doing something that can complement their goals and allow them to do that immediately.
Yeah, and I'd probably add one extra layer to that thinking too, which I like that model of treatment. I use the same thing. But if you've got a patient who has a number of, let's say, for example, a number of trigger points in upper trapezius, and we're getting lots of twitches, and it's a fairly aggressive style of treatment. And for some people, that's okay. Some people, that's okay. They might respond well to it. They've had lots of experience. You know that it's going to be a positive outcome. And then afterwards, they go, oh, I really feel like you nailed it. Like you've got it. My muscle feels like it's had a bit of a workout. And that's often the experience after a lot of twitches, especially from dry needling. If they were then to walk out of your clinic and go straight to the gym and start lifting quite heavily with those tissues, they might feel like they can't do that effectively because of that style of treatment. Now, what you're talking about is reducing inhibition to activation, which is perfect. It's a different style, right? But if that person was to go and exercise and we say to them, oh, no, you can't lift, you can't do anything, then that builds this layer of fear and apprehension around, I might hurt myself, which is not necessarily the case. In the same way that you go and, if you've had done a lot of static stretching or had a deep tissue massage or something, and you're very relaxed, you're not going to jump up off the floor or off the table and go and do hill sprints. You're going to warm up to things, right? So if we've had this aggressive style of treatment in your upper trapezius and you want to go to the gym, do a bigger warm up, do a little bit more activation of that tissue, load the tissue progressively. It's just like anything else. It's like anything else. If you're going in to do exercise, you're going to load tissue. Don't jump into it 100%, build up to it gradually. And that's this case with aggressive treatment as well. You need to build the tissue's capacity back up.
Yeah, and it's just a load modification thing, So if someone, like with that example, think about it this way, right? When someone has post-treatment soreness, what do we say to them? Move, heat it up, get moving. It's the best thing that you can do for it. So if someone wanted to go and exercise after needling, perfect. But let's just look at some volume modification, right? Let's have a deload session. So yeah, absolutely. Go and do your training, whatever that may be. But let's just do it at a little bit lower intensity, lower duration, whatever it may be. So yeah, certainly movement and exercise is fantastic. But yeah, like you said, if you've done too much and gone overboard, then yeah, they're probably not going to have a really good experience afterwards, and might be quite uncomfortable with exercise. So yeah, really, it comes back to getting that dosage right at the same time.
That's right. Yeah. Okay. What else we got there?
Okay, so how do other manual therapies fit in with dry needling? We often get asked this question: should I massage first? Should I mobilize first, then needle? How does this fit in? What's the best order to do these things in?
Yeah. Yes is the answer to all of those questions. Yep. You can do them in any order, providing it makes sense clinically, right? So I see this as two parts. The clinically reasoned answer is I'm going to use dry needling first because I want to reduce the person's pain. And then I'm going to do this other modality because I want to achieve this and this other thing. And it might be two or three things you'll do. Then the other side of it is what are the specific requirements for dry needling that make it difficult to combine with other things? So, for example, if we're going to do a massage first or use massage and there's a lubricant on the skin, cream, oil, wax, whatever, we need to get that off and make sure that the skin is dry and clean and hygienic before we insert the needle. And so there's the mechanics of every modality and how does that fit with the other things. And then there's the mechanisms of effect with each modality and what's the appropriate order based on the presenting client presentation. So those are the two things that I have to try to balance before you can answer that question.
Yeah, definitely. And I think of it like, again, that minimal effective dosage. All right. So what can we apply to get the best benefit with the least amount of stimulation? And that might be that in some people, you might need to give them a little bit of a massage just to calm their nervous system down. All right. And then you can use dry needling to address the pain. All right. It could be that you use some joint mobilization. It could be that you use another modality. It's really about what we can do to settle that patient's symptoms down without doing too much or throwing the whole book at them and doing every technique possible. But there's no real order because it's based on reducing the patient's level of symptoms. So if we look at the basic reasons for dry needling, it's pain modulation. That's primarily why we would use trigger point dry needling, is to reduce someone's pain. So if we can apply that, that's quite a quick and effective intervention. Then the patient might have, you'd go back to a reassessment. They might have a little bit of limited range of motion. Then you might apply some joint mobilization or some massage or whatever you choose to do. So yeah, there's no real order. Again, as you said, it's going to come back to your clinical reasoning as to why you would apply certain techniques for that particular person.
Definitely. Yeah, absolutely. It's such an important question to consider, I think, too. It's like, what's the appropriate order? Where do I put it all? And the thing that I guess, Bo, you and I, really grinds our gears, right? Which is when we see on social media and we see a photo or a video of somebody posts, they're treating their patient and they've got infrared heat lamp on their shoulder, and then there's 6 needles in their glutes, and then they got 4 cups on their back, and then they're mobilizing a hip, and they've got all this going on at once because they think more is better. More is more often than not too much. The human body, and if you're trying to get effective feedback about stimulus from a patient, how can they really tell you what they're perceiving and feeling if there's 4 or 5 or 6 or 7 things going on at once? We want them to tune into what we're doing. We want them to feel the change. Then we want to integrate with that and have them move on from it. If we're treating 6 or 7 things at once, yes, it might be time efficient, but more doesn't equal better.
Yeah, and what's the whole reasoning behind that? If someone comes in with back pain, apply whatever intervention, get them up, reassess it. Was that effective, or what else do we need to look at? What am I missing? You might do something else, then reassess. If everything is just getting thrown at the person at once, it's like, well, that's, again, like you said, a lot of input, a lot of stimulation, but it's just not really that specific for that particular person, their presentation. So
I think it's probably just a case of showing off, really, to be honest. Like it's nice to be able to impress our patients with all of our tools and gadgets and skills, but really it's if you go to that mechanic and they tune up your engine by tightening one screw and you think, wow, this guy's good. He knows what he's doing because he just did one thing and made a world of difference. That's the sign of a really good therapist. The less they do with the greater effect. It's not about more. It's about more.
Yeah, and I really like dry needling for that. Where you can put some needles in, and then you've got that opportunity to just have a chat with the patient and identify some of those other contributors that could be potentially amplifying their pain. That's really important to have that connection, use that opportunity to build some rapport and that therapeutic alliance and all of these factors that go with it. So we don't need to be always doing more things to the patient, address the whole person I think that's really important.
Yeah, definitely. Great. Do we have any other questions?
I think that pretty much covers it
The
from
main
now.
ones?
I'm sure there's more, and if there's more questions, please send them through. We can do more of these episodes.
Yeah, absolutely. Hopefully that's useful. I think those are questions that are timeless, not just like I said before at the start, like not just for newcomers to dry needling. These are the questions that we hear from practitioners who have been at this for years because maybe they didn't understand that at the start, or maybe their thinking's changed and they want to clarify something. So hopefully this has been useful for people. And like Bo said, yeah, if you got any other questions that you'd like to have us answer, we'd be more than happy to do that. So thanks for joining us today.
Thank you.